First, I'd like to acknowledge Charles Marmer and Steve Cohen for actually enabling much of the work that I'll be presenting today. I also want to thank Magali Haas for her really wonderful development of the Cohen Veterans Bioscience organization. It's really a real pleasure to be here. So let's see. Okay. You've probably seen pictures like this before. The one on your left is a hand drawing from 1908. And as you can see, a neurofibrillary tangle really hasn't changed that much in 100 years. Among the issues that I'd like to discuss with you this afternoon, we've heard yesterday about some of the molecular characteristics of Tau. It's a relatively small protein. It's a scaffolding protein that holds cells together, neurons together. It can be hyperphosphorylated in abnormal states. And what I'd like to concentrate on are some of the sites for making in vivo measurement of these markers, which can be in blood, spinal fluid, and from brain. I'll also say a few words about validation. So with respect to the measurement of Tau, these are the sample sites where conventionally fluids are taken. The ventricular CSF, of course, is extremely invasive, under rare conditions done, but is available in surgical suites. The lumbar CSF is the most common, and of course, with the recent funding and purchase of and setup of the Quanterix Simoa device, we're now collecting blood samples for use in Tau assay. A very important thing to consider when looking at Tau assessment is the information that's derived from the fluids that one is gathering. So if you look at this chart here, if you look at the blue line, you'll see in normal individuals, you have about a 500 picogram per ml concentration of the Tau in the ventricular fluid, which drops down to about half of that from the lumbar level and loses another 90% or more by the time it gets to the blood. So we're dealing with very small amounts. And so the question is, are they representative? In work that Silvia Fossati and I have done using the Quanterix device, we've been able to show that there's really a pretty good separation between, in this case, we're looking at our startup study, which is really a proof of concept, looking at normal and Alzheimer, where we had CSF that was matched to the blood. And you can see here that both procedures are giving very similar kinds of separation between these two groups. Now, I mentioned the hyperphosphorylated Tau, and that was discussed yesterday in some detail with respect to neurofibrillary pathology. But I'm showing you this slide here because I want to point out the commonalities, the similarity, at least with respect to normal people and people with dementia, with respect to the relationship between the phospho-Tau and the total Tau. Looks like and you can see the relationships are really very strong. So I'm going to concentrate on the rest of my talk predominantly on the total Tau. I want to highlight here, not to really belabor this too much, but there are a number of neurodegenerative endpoints that are highly correlated with tauopathy, from Alzheimer's disease to Lewy body pathology to ALS, and it just goes on and on. But look inside the red box. There are a number of features that are also related to tauopathy that are less well understood, one being age, sleep disturbances, cardiovascular disease, anesthetics, opiate addictions, and traumatic brain injury. If you look at the effective age, you see that the total Tau has a weak relationship with age. If you look more closely, you'll see that about 60 years of age, there's an increased spread. More individuals are now expressing higher concentrations of Tau, but still, over the lifespan, the slope is rather shallow. If you look at individuals that have dementia superimposed upon that, you see that individuals that are impaired have much higher levels of Tau for the given age relationship relative to the normal. Further, if you look at individuals that have traumatic brain injury, you see that the age at which they become impaired is much lower if they have multiple traumatic injuries. So the development of dementia is 10 years earlier for those individuals that have multiple TBIs. For those individuals that have a single episode of a loss of consciousness following an injury, their advanced year is about 3. So TBI is interfacing with the expression of future dementia decades later, many years later. If you look at, this is a slide that I'm sure many of you really know quite well. It was made by one of our students, Paul Sohn, who's actually here. Paul, where are you? Oh, there you are. Paul actually looked at the relationship of individuals over short periods of time following exposure to TBI relative to control. So what you see basically in a chart like this is that the tau levels are going up, and then they precipitously come down, and they approach normalcy. However, not for everybody. If you look at individuals that have had multiple TBI, and this is data that Silvia Fossati, who directs the laboratory, Silvia, hi, has shown that here with multiple TBI, your plasma tau levels are actually high if you had 2 TBI exposures. A single TBI does not change the relationship, and these are chronic mild TBIs. If you look at sleep, or if you look at risks, if you look at risks for dementia, among the many risks, E4, family history, periodontal, chronic inflammation, sleep pathologies, and cardiovascular disease, principally hypertension, raises the tau level. So in normal people, you can push the tau by virtue of having sleep problems or cardiovascular. If you ask the question about TBI, there is more sleep pathology in people with TBI than in individuals without TBI. And so you have nearly a 4-fold greater expression of sleep abnormalities in people with TBIs. Very common clinical symptom, but now I'm trying to draw the relationship that tauopathy can be either primarily from a TBI or secondarily from a sleep or by the interaction of the two. So let me say a few words about anatomical Karlitz of Tbi. This is work that we've been doing for many years now. Encircled on the left side of the images, you'll see the hippocampal formation, and in red is at the top is the hippocampus. And you see that on the MRI scan, when you go across from left to right, that when people are sick with dementing disorders, they have smaller hippocampi, they have reduced memory. It's an old story. The glucose metabolism, which is the second row, is also lower. And a more recent observation is that the tau pathology, which can be recognized on a tau PET scan, is higher. And it has a very nice distribution that seems to track the older, less specific relationships. Let me point out something here that's of potential interest. If you look at the bottom panel at the green and the red, you'll see that the green, which is the tau distribution, it's a tritiated tau ligand that's used in PET. The distribution you see is that fine line that's highlighted. If you look to the one to the right of that, the red one, you see how it's much broader, it's much more scattered, it's more variable. The tau has a localization closer to the deeper ribbon, closer to the white matter. The amyloid, which is the red one, has a much more diffuse relationship with respect to the cortical ribbon, but we're anticipating a very different profile with TBI. This is what it looks like in Alzheimer's disease, where the tau is closer to the white matter. In the case of TBI, we're projecting that the tau is probably going to be more superficial in the deep crevices of the cell side and in the superficial areas of the gray matter. Untested, but we have the tools to actually examine that question. So it raises the prospect, of course there's no data, but it raises the question, is the progressive tauopathy related to dementia secondary to tauopathy or CTE? Is it a progression of the Alzheimer type, or is it a progression of the traumatic brain injury type? Perhaps there's a way to distinguish these two. Final comment has to do with measurements themselves. The brain gets rid of its waste product, be it amyloid or tau or products of metabolism or anything that it's doing through a system that has been recently termed lymphatic. I'm not going to go into detail about that system, but rather I want to point out there's some key players in that system, which are the Csf conduits themselves and the regulation of those conduits. It's appreciated that in the normal human anatomy, that through the subarachnoid space, there are these granulations that afford the transport of spinal fluid from brain into the vascular compartment, into the venous side. There are channels also in the spinal cord. And it's been presumed for many years, but never demonstrated, that they're also a presumed site in the nasal turbinates, just under the frontal bone at the cribriform plate. So here you see work that we have done with the PET using the tau PET, but we've since generalized it to other radioligands, where you see for the first evidence of CSF, which is in red, actually coming out of the brain and going into a non-extracranial compartment, a non-brain compartment, with an emphasis in the nasal area. This is schematically what we think we're seeing, that below the cribriform plate, which has a black arrow on the piece on the right, you see this yellow dye. And the yellow dye, this is a cadaver. This yellow dye was injected into a cistern, and then it was pushed through, and it's coming out through portals, which are little drain holes at the base of the skull, and you see the egress of the yellow dye outside of the brain. I'm going to show you now the video of the first human that has ever been imaged showing CSF coming out of their brain. You can see that it goes pretty fast. The red is the presumed CSF. But you also see, and you see the CSF by the nose, and you also see it around the brain where it's expected. So it's really pushing the limits of the technology to make these measurements, because we're using a PET camera with a 4mm resolution, which is rather hard to image the arachnoid granulations and those sites. But we are catching it. Okay. And if you ask the question, well, what can you do with this? Well, this is the first time anyone has ever diagnosed Alzheimer's disease from the nose. So let me conclude by saying there's a hierarchy of important steps that the Cohen Biosciences Network has begun to enable us to consider. Certainly starting from the injury, from the ER, and monitoring the progression of illness, which includes understanding something about sleep profiles and clearance. Oh, by the way, I didn't mention something really important, that the lymphatic pathway is largely driven as a nighttime pathway. So sleep is the critical time for the egress of these waste products from the brain. So a sleep disturbance or inflammatory disease or many degenerative diseases have been shown in virtually unanimously in all the animal models to affect the clearance of spinal fluid. We think that in TBI, we're going to be seeing a similar thing, but of course we haven't done that yet. So as I mentioned, so among the key players, we have sleep, we have cardiovascular phenomena, which are adversely affecting lymphatics, and ultimately there's a question of the progressive tauopathy, the progressive inflammation in the brain, the perhaps intervention on the clearance side, and its relationship to cognition and over time. So let me conclude by highlighting three really very wonderful summer students that were with us this past summer, John Spiegel and Paul Sohn, both of whom are here today. And I thank the Cohen Foundation for really enabling their visiting here. And of course, Eduardo Honig, who's not here, he's probably studying at Brown. And our team at NYU, and of course Sylvia Fossati, who is here, and other key players with respect to the imaging and clinical studies that we're doing. So I thank you for your attention and lunch. Okay.
Are the differences, first of all, thank you, phenomenal lecture. Phosphorylated tau versus non-phosphorylated tau, is that different in TBI as it is in AD?
Is the tau molecule itself different, or is the presentation different?
Is the quantitative changes in tau related to phosphorylated tau, or is just absolute values of tau?
In TBI, you have from the time of exposure, you have a very rapid increase in tau concentrations, followed by a high level of the phosphorylated tau as well. In Alzheimer's disease, which is a slow, insidious process which drags on, nobody has really ever seen the evolution of a tauopathy. It's such a gradual, age-dependent phenomenon. So both are very similar in terms of the analytics that are needed to define them, but they're rather different in the profile by which you capture them.
And last question, are you optimistic at all about any tau modulating agents in AD or TBI?
Well, well, not to be overly negative, but I'm a little bit concerned about the relative shallowness of removing the end product of a pathology in the hope of curing a patient when one doesn't understand the mechanism by which the pathology originated in the first place. I'm much more inclined to argue that there may be some greater but limited advantages to targeting some of the coincidental features, such as the sleep disturbances that are secondary, or the cardiovascular features. In other words, can you protect the brain from the tauopathy by adjusting things that are treatable?
Yes, thank you.
It's an indirect approach.
Yes, thank you.
Hi, Stu Hoffman from the VA. Very nice talk. Thank you. So on your last parts about the nasal cavity being, I guess, an exit for the CSF, are you suggesting that that might be a route for detecting tau that's in the CSF?
Yes, I am. We are trying now to use fledglets to actually see if we can, with our Samoa device, which is ultra-sensitive, detect those very small amounts of volumes of CSF that may be amenable. It's a transfer site between the nerve roots, the nerves that are passing through the cribriform plate are passing first into a lymphatic tree and then being moved into the vascular pool. There's not a lot of free tracer or free CSF floating around, but I think there may be enough to capture a view of it. That would certainly be very helpful as a way of validating that it's truly CSF that's coming out of that compartment, which remains otherwise speculative.
Thank you.
Hi, Mony, I was very interested over here. I was very interested to hear you mention the lymphatic system. In the talk that I gave, we identified that clearance was the reason for amyloid buildup, and our likely model for that is the lymphatic system. If there's an error in the vascular coupling to the lymphatic system because they are coextensive, that would give rise to a deficit in clearance, and that may well apply to tau as well as to amyloid.
I think so, Alan. Yes, we're expecting to see a number of analytes. Basically, it's a garbage removal system, and it's kind of interesting actually, because it doesn't matter the size of the garbage that you put into the removal system. It takes everything out. So big molecules, small molecules, just everything goes out, and at the same rate. So it should be possible actually to tag a number of products as a way of visualizing the integrity of this disposal system. MR might be useful too, by the way, which I know you're thinking of.
And this will be the last question. On the garbage removal system, that kind of goes to the circadian rhythm. And, you know, between 10 p.m. and 2 a.m. are supposed to be the key times of getting that deep sleep, which will help with that. And then getting up and getting something like, if you can, 2 hours of blue light in the morning, of ways of protecting the brain. So is that something that
Yeah,
you're...
absolutely. That's what we want to do. We want to actually look to see if we can manipulate sleep. We've started doing studies of people sleeping in the camera to see if we can actually capture the change, if you will, in this function, as well as other anatomical features that are emerging with sleep. Sleep is very rich from the standpoint of imaging. It's also quite rich from other standpoints as well. So there are numerous targets that have yet to be explored.
And there's a study, and I can't remember who did it or when it was done, but looking at Vietnam and the fighters that actually live in Vietnam, because they went back to farming life, were up early in the morning, got the blue light, got to bed, you know, same time, much different life, farmer life. They had much lower levels of PTS in their, you know, in their culture than we do for our guys coming back. So it
would be extremely interesting. I mean, right now, in the field of Alzheimer, in the field of degenerative disease, one can generate predictions that are fairly close with respect to the expression of the dementias. It'd be so interesting to see if we could actually bend that curve.